A very good afternoon, respected learned dignitaries, seniors, and my dear colleagues as well as juniors. It is indeed a privilege and honor to welcome you all to this 13th CPC of this Premier Institute SMS. This institute has been striving to achieve excellence in patient management as well as in academics. Our elite faculty and doctors are dedicated and are disciplined to bring the most advanced and innovative treatment strategies for the patients and add glory to this renowned institute. Today's CPC by the Department of Cardiology, in collaboration with the CTVS department, essentially emphasizes this fact. With this, I would now like to welcome the dignitaries onto the dais. I invite respected Principal and Controller Sir, Dr. Deepak Maheshwari Sir, to adorn the dais. So please adorn the dais. Now I request Convenor of the CPC, Dr. Puneet Saxena Sir, to take the dais. Now I would like to invite the Co-Convener and Additional Principal, Dr. Monica Jain ma'am, to adorn the dais.
Special guest.
I would now like to invite our Vice Chancellor, Sir, Dr. Dhananjay Agarwal, Sir, as a special guest to come onto the dais. Sir, please adorn the dais. I now like to invite Head of Department of Cardiology, Dr. Vijay Pathak, Sir, to kindly adorn the dais. With this, we begin the program. I now request Dr. Dhananjay Agarwal, Sir, our Vice Chancellor, Sir, to say a few words to the gathering.
Today, I am only the part of this institute. As a department of nephrology, I am attending this program just to learn something from the cardiology department. Because all the time I am learning the things from the all different departments. So I feel that today also I will learn something new from this department. Thank you.
Thank you, sir, for the kind words. I now request our Principal and Controller, Sir, Dr. Deepak Maheshwari, Sir, to say a few words.
Dr. Anup Jain sir, my teachers, VC sir, and the doctors, ये मेरा ही department है. So I've seen it growing from last say 15 or 20 years, and the present HOD is my teacher, and बहुत सारा कुछ उनसे मैंने सीखा है, और he's a very hardworking guy. I think cardiology ने इस हॉस्पिटल के लिए नए गोल्स बनाए हैं. हर डिपार्टमेंट बहुत अच्छा कर रहा है. मैं भी यूरोलॉजी वालों के साथ था, नेफ्रोलॉजी वालों के साथ था. सब लोग अपनी तरफ से बहुत अच्छा कर रहे हैं, और ये इंस्टीट्यूट जो चल रहा है और इस इंस्टीट्यूट का जो नाम है, ये इसी वजह से है कि सब लोग अपना 100% आउटपुट दे रहे हैं.
There will be a presentation of the SOP of the CPC by the convener, Dr. Puneet Saxena, sir. Sir, kindly.
Good afternoon, everybody, and a very happy new year. So, in the continuum of CPCs, this is the 13th episode, and for some technical glitches, we could not hold the CPC in the last month of last year, and we are having a new beginning in the new year. So, I wish all the best to the institution to carry on this academic activity. And I like the zeal with which the VC sir said, ki I want to learn. So if the head of the university can say that, then we all must think along that line. And for that, I want to see a full attendance over here, because if the all college faculty and residents come, I think we don't have a place to make them sit also. So I think there has to be some attention from the respective HODs, basically, to make it mandatory, at least for the postgraduates and the senior residents and junior faculty, to be here. because the department which makes the CPC or presents the CPC, they have put all the labor to do so, and it should be acknowledged and recognized, and we all learn from that. So moving on from there, then the CPC, we all know the protocol. Basically, we are discussing the development of the department which is presenting the CPC, and it is very important to know about that, because we don't know many a times that what is going on in which department. And followed by that, we always present a case which is a very unique, or you can say a case of importance, where the multidisciplinary approach is being taken up by various faculties. So it keeps that interesting. So to improve the academics further, I want once again reiterate that presence here should be made mandatory, and Dr. Monica has devised a tool also to monitor, especially the residents, about their presence over here. Wish you all the best. Thank you very much.
I now request Head of the Department of Cardiology, Dr. Vijay Pathak sir, to introduce his department and tell the Institute about the glorious achievements.
Good afternoon, dear friends, and thanks Dr. Deepak for the kind words you've said about me. The department keeps on growing, it will grow ultimately. So this is a brief about the journey of cardiology at SMS Medical College, Jaipur. This began somewhere in mid-60s. International cardiology journals like Circulation, etc., had a spate of original articles on anemia and cardiovascular hemodynamics published from SMS Medical College by Dr. L.M. Sanghvi. Interestingly, the last line common to these publications was that Dr. L.R. Sareen, the superintendent of SMS, kindly permitted the publication. This continued to be the arrangement of cardiology shaping itself over the years. Starting as purely clinical modality based on ECG, stress ergometry, and a discerning auscultation, Dr. K.C. Kotia, Dr. Kailash Chand Kotia, and Dr. S.K. Sharma further impressed upon the need for specialty to diversity. Along with all these years, the invasive hemodynamics was studied in the rooms and labs strewn around the ECG, which is ECG room today of SMS, and the radiology department, which was the place of action when the initial pacemakers were implanted, initial temporary pacemakers. I also had joined MD medicine that time, and I've had the privilege of doing 1 or 2 temporary pacings those days. Mid-1970s, Dr. K.C. Kotia and Dr. S.K. Sharma, Dr. Sushil Kumar Sharma, they were quite active and had made visionary efforts to establish the concept of cardiac rehabilitation at SMS. It was especially benefited by the introduction of Dr. J.P. Bagratta within the team. Dr. Amrit Khalsa completed her DM cardiology from CMC Vellore. And after that, when she joined, the stage was set for the cardiology to take a wing. The first cath lab was started in 1992 under the auspices of Dr. V.S. Baldava as the head of medicine and division of cardiology. 3 years down the line in 1995, the cardiology was finally to take a defining leap towards a separate department which was established at Bangad Hospital with Professor Dr. R.K. Madhok, my very esteemed and beloved teacher, taking it to dazzling heights as its founder had. We had invited him over today, but he has got some viral problem and he had to decline it the last time. The legacy after Dr. Madhok was carried forward by Dr. Anup Jain, sir, who's my senior and he is here. Thank you for being here, sir. Taking a few steps in the 60s to building a huge edifice of academic and excellence, it has been a satisfying journey for the department, which is one of the most sought after departments by DM aspirants. That's a fact. After the central institutes like AIIMS and PGI, I think SMS is one of the heading departments which is in vogue for selection by the DM aspirants. And it invites a very highly qualified, those who had academically achieved a lot at the entrance time that they chose on their own. It's a privilege for us. Initially, there were 2 units with 5 faculty, 1 professor, 2 associate professors, and 2 assistant professors. I was one of the assistant professors at that time in the initial days. Third unit was started in 2011, fourth 2014, fifth unit was 2019, and sixth unit was 2023. So our professors, Dr. S.M. Sharma was unit head, unit 1, Dr. Rajiv Bhagat, unit 2, Dr. V.B. Agarwal, unit 3, myself, unit 4, Dr. Chandrabhan Meena in unit 5, and Dr. Deepak Maheshwari. Also the principal now heads the unit 6 with Dr. Neeraj Chaturvedi and Dr. Sohan as professors. Associates, Dr. Himanshu Mela, Balbir, Dr. Sarita Chaudhary, Dr. Pradeep Meena, and Dr. Dinesh Gautam. Assistant professors are Dr. Dhananjay Singh Shekhawat and Dr. Akshay Shekhawat, with principal specialist Dr. O.P. Khoja and Dr. Sunil Sharma. So it's a big happy family as denoted here. What is a typical day in the cath lab? So we have a variety of procedures to be done every day. We have got 4 cath labs, so it's a busy place. Just for an example, there is a PDA device closure, patent ductus arteriosus device closure, balloon pulmonary valvuloplasty, multiple balloon mitral valvuloplasties, multiple stentings, angioplasties, including rotablators and intravascular ultrasounds, lot of angiograms, sometimes bronchial artery embolization. There is another mode which is essential for heart failure patients, which is cardiac resynchronization therapy, multiple permanent pacemaker implantations, which are now widely done even by our residents who are running their 3rd year, electrophysiology study, and RF ablations. So this is a small depiction. There's a 5-year-old girl suffering from poor weight gain. That means heart failure because of PDA, which is moderate sized. And this is the device that has been placed after the procedure. So this closes the device and makes the patient normal. Another is heavily calcified stenotic vessels on coronary angiography. This gentleman was after CABG 20 years ago, and doing CABG again carries a high risk. So he was taken up for example, there is a tight block in the right coronary artery, which has had a rotablation done, which opens the artery and has kept it flowing well. Pulmonary valve stenosis is quite a common congenital problem. Surgery is the last respite for this. However, we do in our department, we all do pulmonary valvuloplasties. Here is the waist, which shows narrowed segment where the valve is supposed to be the stenotic valve. And after dilatation with the balloon, it is even and smooth. So it becomes absolutely normal with hardly any restenosis. Then there is another patient with severe mitral stenosis who's got a valve area of 0.7 centimeters square. Again, there is a waist here when the balloon is, initially we used to have Inouye balloons from Japan, and opening it up used to reduce the gradient for a long time, and its midterm results were very good. Then there is another patient, and there could be any patient with complete AV block who underwent dual chamber pacemaker done. Then there is Wolff-Parkinson-White syndrome, who was having recurrent palpitations despite medicines, and she's undergone radio frequency ablation with more than 96% complete treatment in absence of any requirement of any medicine. So that's a very rewarding. This is a conglomeration of all the procedures. Needless to say that these complex cardiovascular interventions would not have been possible without continuous support of cardiovascular surgery and anesthesia, as shall also be depicted by today's presentations. Cardiac cath lab has 4 cath labs. In all types of diagnostic and therapeutic procedures are carried out. Cardiac cath for the congenital heart diseases, coronary angiography, peripheral renal carotid angiography, that means vascular angiography as well, carotid angioplasty, renal angioplasty, this is part of non-coronary angioplasties, peripheral as well, iliacs, aorta, electrophysiology, as I told you, WPW and AVNRTs, many tachyarrhythmias, even ventricular tachycardias. Fractional flow reserve, intravascular ultrasound to image what is there within the lumen of the artery. Then relatively new introduction in the department is TAVR, that is transcutaneous aortic valve replacement. And there has been an increase. So surgical requirement for those patients has been removed. Then ASD, VSD, and PDA devices. PDA could be closed non-surgically. Then other procedures like balloon mitral, balloon pulmonary, coarctation of aorta and standing, and closure of ruptured sinuses of Valsalva have all been done and is being done. Endomyocardial biopsy, another major importance where the patient has undergone a cardiac transplantation. Total procedures done this year is as depicted here, out of which devices of different types is 652, total procedures 10,682 in 11 months. And rotablators, towers, 21 towers actually, and endomyocardial biopsy 2. And one of the newest is renal denervation, although patients who are absolutely refractory to even 5 medicines given congenially. This for the first time, in fact, even the entire Rajasthan done by Dr. SM Sharma's unit. This is just a depiction of different cath labs. Unit-wise arrangements are here as such. Dr. SM Sharma's unit is first. Dr. Dinesh Gautam and Dr. Dhananjay join him. Dr. Rajiv is in unit 2, and Dr. Sohan and Dr. Sarita Chaudhary are with him. Dr. V.V. Agrawal, along with Dr. Balbir Parchar and Dr. O.P. Khoja. Unit 5th is me with Dr. Pradeep Kumar Meena. Dr. C.B. Meena heads the unit 5 with Dr. Neeraj Chaturvedi. Unit 6 is Dr. Deepak Maheshwari with Dr. Himanshu Mehla, Dr. Akshay, and Dr. Sunil Kumar Sharma. So multiple research and publication papers have been over the time, which is part of what has been done by department over the time. And there are list research projects which are already in progress. So for a better heart care, we have tried to go and are going step by step up. Always ready to teach. TM course was started in year 2000. At that time, total number of seats were 2. In 2010, they were increased to 8. And in June 2018, they were made 12. So presently, 12 candidates are admitted for DM course. And overall 3 years, 33 DM residents are working in the department. 2 years paramedical diploma course in ECG was started in 2006. 20 candidates are admitted every year for the same. Very heavy OPD. A number of patients attending the OPD is whopping 140,172 patients, when 1,40,000. But this also includes their repeated presences every 2 months. And then there are a number of TMTs, Holters, which are plenty, ECOs 42,000, and indoor admissions 12,219. This is a brief picture of what the OPD is. Then this is again OPD. There are specialty clinics held on Monday as heart failure clinic, pediatric cardiology clinic is Wednesday, pacing and arrhythmia clinic is Friday. The cardiography lab is there, which has got 3 eco labs all the time in the eco lab. Plus we have eco labs in ICU and even in the emergency. So that's a picture of eco lab, then treadmill. Academics, exhaustive DM cardiology teaching program is going on in the department. The attendance is supposed to be 5 days a week. Our students who come for DM get excellent exposure to clinical and interventional work. That is sure. This is the reason why many of them are very well settled now and are doing well wherever they are. Other important achievements are, as I said, we have performed our department under Dr. SM Sharma has performed the first successful renal denervation therapy for resistant hypertension in late 2012, and multiple successive TAVI procedures by multiple consultants. New additions are we are getting new cath lab, new cardiology ward has been there and it's been functional, and new seminar room constructed for all academic activities. And this is the picture of new cardiology ward. Again, this is the emergency. And this is part of emergency where there is proper resident presence and care. Primary PTCAs are done plenty nowadays. It is 24 into 7 hours and is being round down the clock. Facilities present not in all government hospitals in India. Door to balloon time, we try to minimize as short as possible. Cardiac ICU too has got a proper number of beds, BiPAP machines, ventilators, and monitors, and adequate number of patients. We have PCR post-cath recovery area on the second floor. This is the same. This is PCRA, and this is cath lab staff, pictures of ICU and PCRA staff, ward staff. So we have a plenty of them, echo and CTMT. And from here now, a new cardiac tower is under construction and quite close to completion, which will accommodate cardiology and cardiothoracic surgery under one roof. It will have 6 functioning cath labs, emergency, OPD in lower wards, echo, TMT, and all necessary cardiac services for wholesome cardiac care of the patients. Thank you.
Thank you so much, sir. Now I would like to invite our respected principal and controller, sir, Dr. Deepak Maheshwari, sir, to announce regarding the new Cardiac Institute.
I think in cardiology, we are doing a decent work, both clinically and academically. And I'm really pleased to announce that our Institute of Cardiology is coming very soon. The civil work will be over in this month only. And I think placing instruments and other things will take another 2 or 3 months. So this is going to be the one of the best institute in the country. आप लोगों को पता है ना, we are having the maximum beds probably in the world. We are the largest hospital or say a hospital chain in the world. And if we continue like this, IPD tower will come say the last part of the year or probably the first part of the next year. So we will be having all the facilities. I am trying very hard to match international norms and international standards of the facilities we will have. And I have also proposed few changes. Probably we will have some, we will start having some, we will start catering some, say, self-finance persons very soon. So there is going to be changes. And हम सब लोग, आप सब लोग बहुत मेहनत कर रहे हैं. And I am proud that हम लोग जल्दी वर्ल्ड के बेस्ट इंस्टीट्यूट्स में अभी भी शामिल हैं और कुछ बहुत अच्छा कर पाएंगे. तो कार्डियोलॉजी इंस्टीट्यूट आपको मिड ऑफ दिस ईयर देखने को मिल जाएगा. थैंक यू.
Thank you so much, sir. That indeed is a matter of pride. With this, we begin today's case of CPC. I invite Dr. Anand Kapadia, third year SR of Department of Cardiology, to present the case.
Thank you, ma'am. Good afternoon, respected dignitaries, respected teachers from various departments, and dear audience. Today, we will be presenting a case of a young female who was troubled with long-standing breathlessness. So our patient is a 33-year-old female, married since 13 years, resident of Badmer, Rajasthan, beautician by occupation, who came to the cardiology OPD with the chief complaints of breathlessness since 6 years and easy fatigability since 6 years and palpitation since 4 years. Patient was already a known case of dilated cardiomyopathy since 2019 and was on regular follow-up and treatment for the same. However, since the past 2 years, she developed gradual deterioration of her symptoms, which required frequent hospital admissions and gradual escalation of her medications, to the tune that she was put on tablet sacubitril valsartan 50 mg BD, where dose could not be escalated beyond that in view of dose-limiting hypotension and renal dysfunction, tablet metoprolol succinate 50 mg OD limited by bradycardia, torsemide 20 mg OD and spironolactone 25 mg OD limited by hypotension, and tablet dapagliflozin 10 milligram OD, which was the target dose for that medication. So despite these maximally tolerated medications, she had symptoms. So we considered the next line of therapies, which as color coded for the level of recommendations that the current guidelines have. CRT was considered, but because the patient had a narrow QRS rhythm, it could not be done. Ivabradine and digoxin could not be added in view of bradycardia, and verisugat again could not be added in view of dose limiting hypertension. So basically, we were dealing with a case of persistent LV dysfunction, and we needed to be sure that there is no reversible cause of LV dysfunction which could be treatable, so as to label this case a case of DCMP. So primarily, we wanted to rule out ischemia, valvular, hypertrophic, restrictive, peripartum, or toxic cardiomyopathy. And for this, we did a detailed clinical evaluation, which included an exhaustive history taking, especially the family history, any toxic exposure or personal history suggestive of any drug abuse, and very especially the obstetric history to rule out any peripartum cardiomyopathy. A detailed history revealed no reversible cause. So we went on to do certain investigations. First, of course, is the ECG. The ECG revealed a normal sinus rhythm without any significant STT changes, nothing to suggest ischemia. And very importantly, the QRS was narrow, so no role of CRT in this patient. Next and very important investigation was echo, where we basically ruled out any treatable cause. There was no RWA to suggest any coronary artery disease, no significant valvular involvement, no aneurysms or any structural heart disease which could be surgically corrected. Her LV systolic function was severely impaired, EF was 20%, and PA pressures were normal. Dysynchrony parameters assessed for CRT were absent. We did a coronary angiogram considering that the most common etiology for LV dysfunction is ischemia, but the coronary angiogram revealed a normal epicardial coronaries. So we could safely conclude that this was a case of refractory heart failure in a case of idiopathic DCMP, presently in ACC stage D, NYHA3 and Intermax 6. So what are the next line of therapies that can be done for this patient? As per guidelines, the only therapies available for a patient of refractory heart failure of this extent is either going for a durable mechanical circulatory support device or straight away going for the definitive therapy, which is cardiac transplant. So with the diagnosis of refractory HFrEF in a case of DCMP on maximally tolerated medications, the heart team was consulted, which includes the cardiology, the CTVS surgeon, anesthetist, patients and their family members, and a combined decision was taken and patient was kept as a candidate for cardiac transplant since October of 2022. And whenever a patient is enrolled for cardiac transplant, an exhaustive pre-op evaluation is must so as to deem the patient fit for cardiac transplant. We did routine blood investigations, CBC, RFT, electrolytes, LFT, thyroid profile, urine routine were all normal. Serology and virology form a very important part. Triple H was negative, EBV, varicella, rubella, CMV and HSV were all negative, except for a CMV IgG positive, which could have suggested infection by CMV in the remote past. Blood group, very important, was A positive. Chest X-ray was done. Naturally, it revealed signs of mild PVH and LA enlargement and cardiomegaly, but the lung parenchyma was otherwise unremarkable. Cardiac catheterization was done for this patient, which is a mandatory investigation for any patient who has to be taken up for cardiac transplant. The idea here is that we need to rule out irreversible PEH, which becomes a contraindication for isolated cardiac transplant. So the pulmonary artery, mean pulmonary artery pressure came out to be 17 mm of Hg, which was normal. Pulmonary vascular resistance and PVR-SVR ratio were all normal. So patient was considered fit from this end. Next, we did functional testing for this patient, which revealed a 6-minute walk distance, which was less than 300 meters. And exercise testing revealed a peak VO2 equivalent, which was less than 12 ml per kg per minute, which was suggestive of severe functional impairment, and thus makes this a candidate for cardiac transplant. Bilateral carotid Dopplers, aortofemoral Dopplers, USG were all normal. Pulmonary function testing revealed mild restrictive physiology. Pap smear was normal. Gynec, general surgery and psychiatry were consulted and patient was deemed fit from their side. A detailed pre-anesthetic checkup was done by the cardiac anesthetist and they cleared the patient for prospective cardiac transplant surgery. A brief discussion about heart failure. The universal definition describes heart failure as a clinical syndrome with symptoms and or signs caused by structural and or functional cardiac abnormality, which has to be corroborated either by a elevated natriuretic peptide level or evidence of pulmonary or systemic congestion. The overall prevalence of heart failure is increasing, obviously because the longevity of patients is increasing in view of the current therapies. And the estimated prevalence of heart failure worldwide is around 23 million, which is a big number. According to Indian data, ICC NHFR registry was set and in 2018 and has been collecting data since then. Their interim report suggests that around 1% of the general population is affected by heart failure, which amounts to around 8 to 10 million patients, which again is a very big number. And when we compare heart failure patients, Indian heart failure patients compared to the Western world, these patients, Indian patients are younger, sicker, and have much higher morbidity and mortality. And they're unable to tolerate the high level of medications that the Western guidelines suggest. Also, not to forget that the devices and other advanced therapies for heart failure are priced out of range for the Indian patients. So apart from the prevalence of heart failure, which is very high, the prognosis again is very poor. According to one of the studies, the 5-year survival of a heart failure patient is only 25%. And when we compare the prognosis of heart failure patients with the prevalent malignancies for that particular age and sex, heart failure patients do worse than even breast cancers, bowel cancers, ovarian cancers, bladder cancers, and prostate cancers. So we can gauge the severity and of the prognosis of heart failure from this slide. ACC defines heart failure into 4 stages. Stage A is where there is no structural heart disease or LV dysfunction, but the patient has risks for heart failure like hypertension, diabetes, valve disease, or chemotherapeutic medications. Stage B is where the LV dysfunction and structural heart disease has set in, but symptoms have not. Stage C is where symptoms have set in along with LV dysfunction. And stage D is the final refractory stage where the patient is refractory to all the therapeutic and device-related the device therapies for heart failure. Next, so the final answer to a patient who has got refractory heart failure is probably only cardiac transplant. And the reason why we chose this CPC, this as a case for CPC, is that this might not seem to be a big diagnostic challenge, but this definitely is a therapeutic challenge. In the sense that for a cardiac transplant to occur, we need the specialization of these many faculties and maybe many more for a cardiac transplant to occur. This involves obviously CTVS, which takes the center stage doing the surgery along with the help of cardiac anesthetist. Cardiology, which is involved right from the first contact of the patient to pre-op evaluation to intra-op management to post-op care. General medicine and pediatrics form the base department. Pathology and microbiology for all the investigations that needs to be done. Psychiatry, because this is a big psychosocial event in the life of the patient. A proper pre-op and post-op counseling is required. Radiology for all the radiological investigations. Nutritionist, which is very actively involved in the perioperative care. Pharmacology for all the drug interactions and drug level monitorings that has to be done. Neurology, oncology, nephrology, gynecology, general surgery for all that can go wrong post cardiac transplant. And we cannot belittle the contribution of transplant coordinators, who are basically the bridge between medical personnel and the administration. And they are required right from the registration of the patient to all the clerical work that is required. A brief history of cardiac transplant. As many of us might know, the first transplant was done by Dr. Christian Bernard. The recipient was a middle-aged male with advanced ischemic cardiomyopathy, and donor was a young woman who was a victim of road traffic accident. The initial patient survived 18 days, but ultimately died of pneumonia. He did not stop there. He went on to do 53 transplants later. In India, the first transplant was done way back in 1968, which was only the 6th in the world at that time. But the patient died and heart transplant program could not take off from there. It was only in 1994, after the organ transplant bill was passed, Dr. Venugopal at AIIMS did the first successful heart transplant. The patient lived on, and since then there is no looking back. NOTO was established in 2014 and has been a major booster for heart transplant program in India. What we have achieved so far, there are at present 70 centers which across India and span across 19 states, which have performed heart transplant till March of 2024. And SMS stands tall amongst those. And if we see this pictorial description, the maximum number of transplants are done in Chandigarh, Delhi, and Tamil Nadu. And apart from Chandigarh and Delhi, Rajasthan is the only state in the whole of North India to have offered a heart transplant. Till March of 2023, according to the annual registry report, 1328 heart transplants have been done in India. In 2023 alone, 102 heart transplants have been done, and 62 in 2024 alone till July of 2024. And very proudly, our institute have done 3 transplants of these 62. Sir, last year 3, 4, and heart and lung transplant as well. So the long-term outcomes of cardiac transplant, according to one of the data from one of the centers in Tamil Nadu, the 1-year survival in Indian setting is reported as high as 81%, which is comparable to the international data, which reports 1-year survival of around 91%. So we see we are at par with the international standards when it comes to heart transplant. Also, not to forget the survival curve for patients who have undergone heart transplant. At 5 years, the survival rate, as depicted in the diagram, is around 75%, which is a very big booster to the unintervened heart failure patients, where the survival could have been just 25%. So, cardiac transplant is a big life changer for these patients. Indications, it could be for chronic heart failure, stage D patients requiring frequent admissions, worsening renal functions, requiring frequent episodes of ventricular arrhythmia, or for acute heart failure, those on maximal dose inotropic support, mechanical support, or refractory edema or refractory ventricular arrhythmias. Contraindications have to be ruled out: active infections, chronic liver disease, chronic kidney disease, recent stroke, uncontrolled diabetes, active malignancies, severe lung disease, recent pulmonary embolism, severe PAH, PVR more than 4 Woods unit, psychosocial support, especially any substance abuse, morbid obesity, and multisystem disease all make it a contraindication for isolated heart transplant. Preoperative assessment we had already discussed: routine blood investigations, urine analysis, PFTs, X-rays, USGs, infectious serology. Very importantly, vaccination has to be done before the transplant itself. Live vaccines like influenza, pneumovax, and hepatitis have to be given. Because post-transplant, these are contraindicated and risk of infection increases post-transplant. Screening for common malignancies for that age has to be done. High-risk behaviors have to be ruled out. Mental health evaluation has to be done. ABO blood grouping and HLE typing is very essential. Panel reactivity antibodies, another very important investigations which has to be done. And the higher the percentage of panel reactivity antibodies suggests that the patient has sensitivity or immune reactivity to those number of prospective donors. So it has to be less than 10%. Registration for cardiac transplant, NOTO has got its specific guidelines. A patient can only register to one transplant center, and the status of the patient has to be regularly updated by the center. Waitlist prioritization, they are categorized into 3 categories. First is emergency, those on VADs or intra-aortic balloon pumps. Priority 2 is semi-emergency, those on inotropic support and maintaining hemodynamics. Priority 3 is elective, those who are hemodynamically stable and electively waiting for heart transplant. Criteria for suitable organ donors according to NOTO, apart from general criteria for brain dead donors, those who can give cardiac, who can be a prospective cardiac donor, age has to be less than 60 years, more than 40 years needs a coronary angiogram, no history of heart disease, echo should be normal, and inotropic support, if at all required, should be in minimal doses. Cardiac arrest, if at all occurred, should have been brief. Criteria for allocation of heart, blood group matching is the first step. O heart goes to O heart first, if not then to A or B, and if not then to AB. Similarly, A or B will go to AB, A or B, and if not then to AB. AB can only go to AB. And once this allocation is done, the hospital with the first 2 recipient in the order of allocation will be informed. And if the first recipient is not confirmed into us, we go on to the next prospective recipient. Size and weight mismatch is another important consideration as against other organ transplant surgeries. No more than 20% mismatch is acceptable. Larger hearts can go to smaller hearts, but smaller hearts cannot go to large recipients. Distance is another key consideration in view of the cold ischemia time. And if an organ is retrieved from a government hospital, the first priority is given to recipient who is registered at a government hospital, as in our case. Next, I would like to invite Dr. Sandeep Mahala from CTVS to discuss the perioperative course of this patient.
Good afternoon, respected teachers, and good afternoon, dear colleagues. This was myself, Dr. Sandeep Mehla from Department of CTVS. I'm third-year resident. These presentations were made by help of Dr. Pritansi under supervision of Dr. Rajkumar Yadav, sir. Sir has been recently retired, and sir has come to our presentation at special request. This was our 6th heart transplant, and we are going to discuss about quality of life after transplantation. The objective of heart transplant has been discussed, and heart transplant is done basically in those patients who are refractory to other therapies like medically or surgically. Anything cannot be done and patient's life expectancy is less than 1 year, then we will go for heart transplant. How this transplant is different than previously done. This was the first heart transplant where organ was brought 335 kilometers away from Jaipur by a commercial flight. Here are donor details. The heart donor was a brain dead patient, Anita named, 24-year-old female patient who was a victim of road traffic accident in Jodhpur, and she was admitted in neurosurgery ICU AIMS Jodhpur. And Soto, once our family gave consent for organ donation, Soto alerted at 5 p.m. 28th of July, and once we received a message about that a donor heart is available, our team responded under the leadership of Dr. Rajkumar Yadav sir, and all the procedures were started. We started for our searching for registry of A positive donors. Our recipient was found in Bardmer, around 400 kilometers from here, and a donor heart was available at Jodhpur, and operation has to be done in Jaipur. And this was a challenging task, and without support and without coordinated efforts, this could not be possible. Our recipient, Pooja, they gave consent at 6 p.m. in the evening, and they started from Bardmer at 9 p.m. and they reached to our hospital at midnight, 2 o'clock. And for the cross-matching, transplant coordinator of Jodhpur Hospital, Jodhpur AIMS Hospital, he started from there with the sample of the donor's heart, and he reached SMS Hospital, and donor and recipient both samples were taken and sent to the transplant immunology lab of Mahatma Gandhi Hospital. All the reports, ABO, DSA, CDC came out to be negative, and a patient was fit for transplant. Then this is our team under the supervision of sir. They reached AIMS. They started from Jaipur at midnight, 12 o'clock, and they reached AIMS Hospital by 6 o'clock, and then the donor Anita was shifted to operation theatre, and around 8:30 the operation started along with the other teams of liver and kidney. Donor heart was harvested. Harvestation was completed by 10:30 a.m. in the AIMS Jodhpur. Then the cold ischemia time started. With the coordinated efforts of Jodhpur and Jaipur administrations and hospital administrations, a green corridor was established, and the heart was transported from AIMS Jodhpur to Jodhpur airport within 10 minutes. Then it was transported by a commercial flight to Jaipur within 45 minutes. And then in green corridor, it was transported to SMS Hospital around 11:45. And our transplant surgery started around 12 p.m. So it was around 1.5 hours time, cold ischemia time. And then I'm going to discuss about some details of organ procurement. For organ procurement, first we will start with median sternotomy and laparotomy. Pericardium will be opened and all the adhesions will be removed. Then patients, the donor heart is checked for cardiac injury, congenital anomalies and other anomalies. Then in this picture, This is superior vena cava cut, this is inferior vena cava cut, and this is right superior pulmonary vein is cut before giving cardioplegic solution, because it will distend the heart and results may not good as we wanted. After once all these adhesions removed, then cardioplegia solution is given, around 2 liters HTK solution is given, and then once heart stops beating and it's preserved well, then it is taken out from the donor and it is checked again for any anatomical or any debris present, and then it is trimmed, and it is in this picture it's shown that it will be transported in a bag where cold slush will be there. Once organ has been retrieved, trimmed, and then there are techniques available for transplantation. There are two techniques. There are two type of transplant. One is orthotropic and one is heterotropic. In our case, we did orthotropic heart transplantation, and there are two techniques available for orthotropic heart transplantation. One is bicaval and one is biatrial. In our case, we did transplant by bicaval technique. For heterotropic transplant, it's also known as piggy heart. There are only two indications for heterotropic transplantation. One is when there is marked elevation of recipient pulmonary vascular resistance, or second one when the heart which is given to patient is smaller for the patient. If patient's weight is more and heart is small, then it will support, and it is in this picture it is shown as that this is donor heart and this is native heart, and donor heart is transplanted on the native heart, so it will support. In bicaval technique under general anesthesia, all the routine things are done. TE probe is placed and heart is exposed by median sternotomy. When the donor heart is imminent to arrival, then at the time cardioplegia is given and the native heart has been removed. In this picture, the native heart has been removed. These are the superior vena cava, inferior vena cava. This is aorta, pulmonary artery, and this is the cuff of left atria with intact all four pulmonary veins. In this picture, the heart has been, the diseased heart has been removed from the body, and now it is time to transplant or implant new heart. For new heart implantation, the LA stitching is started first because it is a posterior structure, and once this has been completed, then we will start with inferior vena cava, then aorta, then superior vena cava, and pulmonary veins. This picture is showing where all the anastomosis, superior vena cava anastomosis, aorta anastomosis. This is main pulmonary artery, this is inferior vena cava. Once the new heart has been transplanted, then we will check for, we will gradually wean off from the CPB, and we will check for the new heart, how it is functioning with the help of TE, and any residual air is there. This is new heart inside the body, and it started beating. Once new heart is started beating, then we will gradually wean off the bypass, and we will we will close the patient, and the post-operative treatment management will start. The post-operative management was very hectic in our case. The patient was kept in BMRC 5 transplant block. Absolute sterilization was maintained. Round the clock, one doctor and two nurses were present by the side of the patient to monitor vitals every second by second. In post-operative management, we started with immunosuppressive therapy and broad-spectrum antibiotics and routine treatment. Immunosuppressive therapy we started was basiliximab and methylprednisolone in injectable form. Then we started, we shifted patient on triple regimen, oral immunosuppressants in the form of tablet tacrolimus, mycophenolate mofetil, and prednisolone. This is the treatment chart what we started. There are some guidelines for early post-operative care. In early post-operative care, we will monitor 12-lead ECG, arterial pressure monitoring, direct measurement of CVP, measurement of left atrial and pulmonary artery wedge pressure, cardiac output, continuous measurement of arterial oxygen saturation. Intra-op, we will monitor by transesophageal echocardiography, and post-operative, we will check heart by transthoracic echocardiography. As the new heart is denervated, it has gone through a period of around 1.5 hours. There may be some changes in the myocardium ischemia, and the new heart will show some signs of bradycardia that can be managed by either pharmacologically or by arterial pacing. In our case, we started inotropes were like epinephrine, norepinephrine, vasopressin, dobutamine, and milrinone, and inotropes and steroids were gradually tapered. We encountered some post-operative challenges, like in the first week of transplant, we encountered sepsis with acute kidney injury, WBC counts, serum creatinine, blood urea were raised, PCT and anti-proBNP were also raised. In early post-operative period, there were findings in the echocardiography that heart was working less, ejection fraction was less than 50%, IV septum was jerky, which were gradually improved. And as a protocol, we did routine investigations and culture and sensitivity twice in a week. With the coordinated efforts of interdepartmental team, patient came out of sepsis and low cardiac output. We especially thank our medicine department, sir, Ramji sir and Vishnu sir, microbiology by Rajni ma'am, cardiology by CB Meena sir, and nephrology department, Dhananjay Agrawal sir and Dr. Abhishek were very helpful in the post-operative management of the patient. After 14 days, all our vitals, LFT, KFT, CBC, echo were within normal limits. Then we planned for discharge. Patient was shifted to a private isolated department where we visited her daily and observed, and all our routine investigations were done from there only every week. This picture is showing our team at the time of discharge, and these are some media highlights. And now, when after 5 months, patient visited to our department, and after 5 months, patient last time when visited, we have taken interview of patient. Patient is doing fine, and for further management, I would like to invite cardiology team.
Thank you, Dr. Sandeep. Now coming to the follow-up phase, the post-op phase of this patient. Patient was followed up every week in the first month, followed by every 2 weeks thereafter. During the most recent follow-up visit, she was asymptomatic and could carry out her routine household activities without any symptoms. We did a routine investigations for her. CBC, RFT, LFT, electrolytes were all normal. Markers of cardiac injury, troponin, NT-proBNP, PCT, and CRP markers of inflammation and infection were all negative. Tacrolimus levels were in the range that were recommended for that particular time since the transplant. We did an ECG. New heart shows a different kind of ECG, normal sinus rhythm with RBVP, nothing to suggest any abnormality as such. Chest X-ray was done, which showed a very healthy looking heart, normal cardiothoracic ratio, no signs of PVH or PEH, and lung parenchyma seems unremarkable. Suture lines from previous surgery can be seen. 2D echo was done, which showed a normal LV and RV systolic function with a normal EF of 55%. So after routine investigation, as a part of routine surveillance, we decided to perform endomyocardial biopsy, which is as per guideline recommendations. After explaining the patient the risk-benefit ratio and taking due consent, right femoral venous access was taken for biopsy. We introduced a 9 French sheath through which a 7 French guiding catheter was inserted. This is the guiding sheath, which is the 7F sheath, through which we can see that there is a balloon tipped catheter, which is the Swan-Ganz catheter, which helps us locate the guiding sheath to our area of interest. After that, this catheter is removed, and next we introduced the instrument of biopsy, which is the bioptome. This is the bioptome inserted, and it is hitting the ventricular septum, which is our area of interest from where biopsy will be taken. The operator end has a blade, has a handle which opens the blade, and unfortunately we cannot play the video, but the blades have opened up, and it will basically bite a chunk of tissue from the ventricular septum. And once we have the tissue in hand, we will remove the bioptome and empty this into the concerned preservative. We do this 2 or 3 times until we get an adequate sample of tissue, and then we send this tissue for histopathological evaluation. Briefly discussing the post-op period of a heart transplant patient, there are 5 major concerns. First is primary graft dysfunction, second is rejection, third is infection, fourth is malignancy, and fifth is cardiac allograft vasculopathy. This graph shows the most common causes of death in a post-transplant patient. The pink one is the graft failure, which is the most common etiology, followed by infection and followed by multi-organ dysfunction. Primary graft dysfunction, it is defined as graft dysfunction within 24 hours after transplant in the absence of hyperacute rejection, pulmonary hypertension, or known surgical complications. Predisposing factors are pre-transplant mechanical support, increasing donor ischemia time, anoxia-mediated death, or prolonged donor resuscitation time. Protective factors, however, are those with donor blood type O and donor hypersystolic functions on echo. Treatment is only supportive, and ECMO should be instituted as and when required. Infection is another major concern, obviously because of the use of immunosuppression. Risk is greatest in the first year post-transplant. Vaccination have to be done beforehand. Routine prophylaxis are recommended, especially for pneumocystis jirovecii, we give Septran. Cytomegalovirus, we give Valganciclovir. Candida, we give fluconazole. And in some cases, we need prophylaxis for herpes as well. Malignancy is another concern, again due to risk of immunosuppression, skin cancers being the most common, followed by non-Hodgkin's lymphoma and lung cancers. Post-transplant lymphoproliferative disorders are a specific form of lymphoma that needs to be suspected in the follow-up phase of any heart transplant patient. Compared to the general population, the risk of malignancy increases as high as 6.2 times. Next major concern is cardiac allograft vasculopathy. This is nothing but narrowing or occlusion of the coronary arteries, and it increases as the time since procedure increases. And this is different from our routine atherosclerotic coronary artery narrowing, which are eccentric and focally scattered. As you can see in the lower image, there is diffuse luminal narrowing and concentric hypertrophy of the intima. So if you do an angiogram for this patient, we might find that the vessel is diffusely reduced in caliber right from the start till the very end, which might give us an impression of a normal looking coronary, but it actually is not. And for this reason, the ideal investigation modality of choice is intravascular ultrasound, where we can actually measure the width, the thickness of the vessel wall. This cardiac allograft vasculopathy, the presentation is different from routine coronary artery disease because these are denervated hearts and they will not produce angina. Heart failure is the most common presentation. Treatment, revascularization is not very effective because of diffuse nature. Risk factors are either immune mediated or non-immune mediated routine coronary risk factors. Next and very important concern is rejection, and it may be categorized based on immunity, cell-mediated or antibody, and based on severity of rejection. Surveillance endomyocardial biopsy plays a very important role because it takes time for firstly, there will be histopathologic changes followed by a latent period, after which there will be gradual decline in LV function, followed by a latent period, after which the patient will develop symptoms. So if we wait for symptoms to occur, we might have missed out on the golden period for intervention in these cases. According to one of the registries, the prevalence is as high as 22%. Risk is higher in younger women and those with higher plasma reactive antibodies. Immunosuppressive therapy in brief, induction therapy is loading the patient with immunosuppressants in the perioperative period. Maintenance is in the postoperative period, giving immunosuppressive drugs. And for acute cardiac rejection, if it is cellular, we give pulse steroid therapy, and antibody mediated reaction, we give rituximab, bortezomib, or eculizumab. Induction drugs, we use basiliximab. This cannot be seen. IL-2 receptor, and it is an IL-2 receptor antagonist. Basiliximab was used in our case for induction. For maintenance, we use tacrolimus, and as an anti-proliferative, we used mycophenolate mofetil, and steroid we give prednisolone. A brief about endomyocardial biopsy. Disorders of myocardium are one of the challenging areas, and endomyocardial biopsy helps us in diagnosing these. Indications are heart failure of unknown etiology, primarily acute decompensated heart failure, where we differentiate fulminant lymphocytic myocarditis from giant cell myocarditis. Cardiac sarcoidosis, patchy involvement reduces its diagnostic yield. Hypersensitivity myocarditis, suspected anthracycline cardiomyopathy, and heart failure with restrictive pattern, where we need to differentiate idiopathic RCM from amyloid. And a very important indication, as in our case, heart transplant surveillance. According to the Western guidelines and Minneapolis Heart Institute protocol, the frequency of biopsy in a post-transplant patient is as high as every week in the first month, in 2 to 3 months, every second to third month, every 2 weeks, then every 4 weeks for 3 months, and then every 8 weeks for next 3 months, and after a year as needed. But because of the limited resources in our settings, we restrict our frequency to much lesser. Preparation, patient has to be off anticoagulation. It can be done under biopsy can be done under fluoro guidance, or even under ultrasound and 2D guidance. Vascular access could be anywhere from right internal jugular, left internal jugular, or right or left femoral vein. Bioptomes come in two types: pre-shaped or flexible. We use the flexible bioptome as seen in this picture. Complications are has to be kept in mind. Perforation is the most fatal one. Heart blocks can occur because the ventricular septum lodges the AV node and the bundle branches. Pneumothorax can occur. Pulmonary embolism is a concern. Venous hematomas and arteriovenous fistulas are local site complications. And now I'd like to invite Dr. Kiran Saini for discussing the biopsy.
Okay, so I'll be dealing with the endomyocardial biopsy in brief. So it is one of the gold standard for diagnosis of allograft rejection. It has a high sensitivity and a low complication rate. So an adequate biopsy requires at least 3 to 5 fragments, which should be at least 1 to 2 mm in size and immediately fixed in 10% buffered formalin. If the clinician is expecting focal myocardial lesion, additional sampling may be required. For molecular tests, it should be fixed in liquid nitrogen at -80, and for electron microscopy, 2.5% glutaraldehyde is the ideal fixative. So this is an exhaustive list which shows the diagnostic potential of endomyocardial biopsy, which has already been discussed by Dr. Anand. So I'll be skipping. So before proceeding with the biopsy in this particular case, I would like to highlight the grading system proposed by the International Society of Heart and Lung Transplantation for cellular and antibody-mediated rejection. So this was first proposed in 1990 and further modified in 2004. So there are basically two types of rejection. The first one is the acute cellular rejection, which is graded into grade 1, 2, and 3 depending upon the inflammation and myocyte damage. So this figure will illustrate in detail about the rejection criteria. So on the left side of the slide, you can appreciate how a normal myocardium looks like. We can appreciate the fine cross striations, intercalated disc, a centrally placed nuclei, and branching of the healthy myocardium muscle. Whereas in case of acute cellular rejection, if the rejection is mild, grade 1, we will see mild perivascular and interstitial inflammation. In grade 2, we will see at least two foci of inflammation with 1 or 2 foci of myocyte damage. Whereas in grade 3, we will appreciate diffuse inflammatory infiltrate and multiple foci of myocyte damage. And basically, the incidence of acute antibody-mediated rejection is low, as the high-risk patients are already treated prophylactically with therapy. So antibody-mediated rejection is more of a clinico-pathological entity rather than a pathological entity. It is characterized by cardiac dysfunction, donor-specific antibodies, certain histological changes, and immunopathological changes. So histopathological changes seen in antibody-mediated rejection are endothelial cell swelling, intravascular macrophages, and perivascular edema. Whereas the immunopathological changes seen are positive staining for C4d complement factor around the capillary endothelial cells. So basically this grading is done as grade 1, 2, and 3. But grade 1 is further categorized as H plus and I plus. If only histopathological changes are positive, it is graded as grade 1 H plus. If only immunopathological changes are seen, it is graded as 1 plus. Now in grade 2 and 3, both histological and immunopathological changes are seen. However, in grade 3, the histopathological changes are more severe. So in this particular case, we received a very tiny fragment, which was almost 0.1 centimeter. So most of the biopsy comprised of hemorrhagic tissue, as can be seen. 80 to 90% of the biopsy comprises of hemorrhage, and at the periphery, we can appreciate some cardiac muscle. At high power, we can see that the cardiac muscle seem to have increased eosinophilia. Cross striations are not visible. Intercalated disc is not visible, and we can appreciate some mild interstitial inflammatory infiltrate. Now, this infiltrate could be due to some drug toxicity, could be due to myocarditis. However, in view of the small size of the biopsy, a definitive diagnosis cannot be given. So, just to show you all how a adequate biopsy looks like. So this is a biopsy which was done in another heart transplant patient, which was done almost 2 years back. So this is a adequate biopsy specimen in which we can see that there are multiple fragments of endomyocardial tissue. On high power, we can appreciate the cross striations, intercalated disc, a centrally placed healthy nuclei, and these are the small capillaries, and only occasional inflammatory cells can be seen. So this is a healthy biopsy in a heart transplantation. So this was graded as grade 0, no rejection according to the 2004 criteria. Now these patients are very prone for infection as discussed earlier. So there is a high risk for myocarditis, which can be due to viral, bacterial, fungal or parasitic causes. So endomyocardial biopsy plays a very important role in the diagnosis of myocarditis. So basically we take into consideration inflammation and fibrosis, which is categorized by Dallas criteria. So we see the distribution, extent and type of inflammation. So here are two examples of viral active myocarditis. The figure A and B, we can see there is multifocal inflammation and arrowhead denotes the area of myocyte damage, whereas in figure D and E, we can see severe inflammatory infiltrate and multiple foci of myocyte damage. Both these cases were positive for adenovirus and enterovirus, which was confirmed on PCR gel electrophoresis. In some particular cases like CMV infection, we look for intranuclear basophilic inclusions and coarse red granules in the cytoplasm. So these patients are given high dose of immunosuppressants, so they are also prone for drug toxicity, but the role of endomyocardial biopsy is limited. Histology revealed non-specific features like necrosis and mixed inflammatory infiltrate. So it is replaced by non-invasive techniques like stress echocardiography, MRI and angiography. Now I would like to invite Dr. Anand to continue with the case.
Thank you, Dr. Kiran. So finally, this is our patient at the end of 5 months post-transplant, doing absolutely fine, and we are in constant touch with her. And due to a technical glitch, we cannot play the video, but this is our patient at the end of 5 months, dancing to the new heartbeats. So to conclude, an exhaustive heart failure management program, which includes a cardiac transplant, we can change the life of the patient. These patients who are terminally ill can be given a new life, and this is a big life changer for these patients. And with advancing therapies and the resources that we have in hand, we intend to do many more of these. Thank you for your patient listening.
Thanks to the entire Department of Cardiology and CTVS for the excellent presentation.
Wants to speak something about the transplant program because we have discussed transplant today.
It was a nice presentation from the cardiology department in association with the CTVS department, and we had a close association with them. I have few suggestions that in transplantation, in particular in cadaveric transplantation, CDC crossmatch, we keep as sufficient for going for transplantation, because we started matching the group 1 and group 2 other antibodies. A lot of rejections were there, and we found that results are good with CDC crossmatch. Second thing, I want to add that thing, when the patient is on a high risk, particular multiple pregnancy and other patients, we can use the ATG as an induction agent, which are found to be better than the simulactin. Third thing is we have seen in routine practice that for cardiac transplantation, a lot of diuretics are given, because diuretics causes the volume contraction, and we feel that it causes acute kidney injury, and simultaneously when they receive tacrolimus. So tacrolimus is having a lot of nephrotoxicity, and it elevates the creatinine, and ultimately when GFR drops, lot of hemodynamic changes are there, and we have to modify the dosage of drugs, and simultaneously the chances of hyperkalemia is there. So we must be vigilant about the volume maintenance of the euvolumic status. Third thing is that we are thinking for combined transplantation, cardiac and kidney transplantation, because we are having just now we are getting the confidence with the cardiology people. We were thinking from long back that we should start combined transplantation, but as we are doing routine cardiac transplantation, now we can think in future about the combined cardiac and kidney transplantation to benefit this type of the patient. Third thing I want to add that we should not disclose the identity of the patient, which in last slide we have disclosed the things. We should keep the privacy and identity of the patient. And I have learned a lot of things from these this type of the transplantation. Thank you.
Thank you, sir, for the highlights. I would now like to invite Dr. Monica Jain, ma'am, and Shivankan to introduce the new digital logbooks.
So before proposing the vote of thanks, I wish you a very, very happy and new year and a prosperous one too. And let us all vouch upon that we should take the SMS flag flying very high. So post Makar Sankranti festival also. So happy Makar Sankranti post festival and happy new year. It's a matter of indeed a pleasure and a pride for our institution again that we have taken up a digital logbook for PT students, first of its kind ever done at any other institute without any cost. I would like to emphasize that it is without any cost because in many institutes at Gujarat, they are using a software which is quite costly. So I will invite our VC sir, Dr. Dhananjay Agarwal sir, and Dr. Deepak Maheshwari sir to please grace the dais. I will also call upon Dr. Vijay and Dr. S.M. Sharma sir to kindly join this, the inauguration and of this digital e-logbook. So I just want to show you the document. It has been developed by Medical Education Unit. Dr. Shivankan Kakkar was instrumental along with me to decide upon how it has to be done. Dr. Deepak Maheshwari sir has always been encouraging with an open heart because he's a cardiologist. And so he has also inspired us to do something new. And so this is the logbook. I'll just show you the
Officially
picture.
launch.
And sir से मैं request करूँगी कि आप officially इसको launch कीजिए. इस पे click कीजिए sir.
Please come boss.
Sir आप दोनों click कीजिए.
क्या
We will be showing you that logbook. You just click on this the cursor.
Yes.
And here it goes.
Yes.
So this is a logbook postgraduate which is developed by our institution at this moment of immense pride. And let me show you. Yes, it may be implemented for DM and MCH. And important point is it is a dynamic document. Every day you don't have to run about the resident. This will be a dynamic document on Google Docs, and the contents can be made up, customized depending upon the departmental requirement. So this is we have developed it for Department of Pharmacology, and as you can see, there is the content, the title. Shivankan quickly just.
Okay. So this
certificate and all. So this is this is the structured training program. You have the index, and initially what you will have will be the certificate. The important point is this dynamic document has to be kept in the soft copy, and the student appraisal form or student activity form is the only requirement which is to be submitted to the examination section for marking it for the logbook. So this is the certification in which you have the sign of postgraduate guide with the head of the department, and the rest of the things will be personal profile. All this is a dynamic document, details of the posting. Important thing which I have done is the summary of CPC attended. All the certification courses which are required for eligibility will also has to be included. The leave record of the department has to be included. Then participation in academic programs, the conferences, workshop has to be included. Extracurricular participation and awards, publication, title, author, indexing, name of the journal, all citation, all this is included. And of course, the internal assessment results are also to be included. Details of DRP with a summary report has to be included because this is fill in the blank again. So the structured training program, the seminar attended and seminar presented has to be included with the name of the moderator and the respective signature. This can be visible to the respective guide, to the respective persons, respected faculty members and the head of the department. So this is a very dynamic document and it does not take any effort, and plus no wastage of paper is done. So this detailed program will be discussed in the further meetings of the MEU. But yes, it is a very, very good effort in terms of SMS Medical College. Congratulations, Principal Sir, and VC Sir, and everybody else in there, and congratulations to the medical education unit team too. Congratulations.
Real-time tracking and live.
This is like real-time tracking and
Live document.
live document. So with this we end with today's CPC program. Thank you so much for attending. And as I have promised and Principal Sir has insisted regularly, please do come into the CPC programs because it takes about a lot of effort from everybody who has been involved in conducting this. So audience will be the success. So please do come, and order is soon to follow after this CPC, which you have to take care of. Thank you all very much. Wishing you again a very happy new year. The tea and the pakoras are waiting outside. Thank you all very much.